Hello, everyone. I'm Dr. Matthew Martinez. I'm the Director of Sports Cardiology and the Hypertrophic Cardiomyopathy Program at Atlantic Health System and Morristown Medical Center in Morristown, New Jersey. I am joined by Dr. Doherty and Dr. Honeycutt for a panel discussion on the use of AI for identifying hypertrophic cardiomyopathy, specifically in HCA. Dr. Doherty and Dr. Honeycutt, please introduce yourselves.
Thanks so much, Dr. Martinez. I'm Brian Doherty. I'm the director of the Hypertrophic Cardiomyopathy program at Centennial Hospital in Nashville, Tennessee. Very happy to be here and participate in this discussion.
Thanks for joining us.
And thank you for having me as well. My name is Dave Honeycutt. I'm a general cardiologist also at TriStar Centennial Medical Center in Nashville. I have an interest in general cardiology as well as research and serve as a member of the Research Operations Council within HCA, which is my basic involvement in this discussion.
Terrific. Thanks, Dr. Honeycutt, Dr. Doherty, for joining us. Before we get into the panel discussion, we thought we might provide some background and somewhat level set the viewers about a basic understanding of hypertrophic cardiomyopathy, patient experience, and what a clinical management program might look like for those who are evaluating, and then, of course, for the patient's journey through hypertrophic cardiomyopathy. Let's get started with that. So hypertrophic cardiomyopathy is a common disease. It affects somewhere between 1 in 200 and 1 in 500 people worldwide. Over 120 countries and 88% of the world's population have had some description of hypertrophic cardiomyopathy. These are figures from a paper from Barry Marin and colleagues from several years ago. It's considered the most common inherited cardiac disease and one of the more common causes of sudden cardiac arrest, especially in those under the age of 35. Now, a patient journey may look like this, where most patients with hypertrophic cardiomyopathy live well into their 70s and 80s. They're often low risk, and many are without symptoms altogether. We evaluate them for a gene mutation, which we identify somewhere around 40% of the time. And then there's follow-up throughout their lifetime to determine if they fall into one of the profile pathways here, if they didn't already present with one of the pathways here as their initial presentation that brought us to the attention that I wonder if they have hypertrophic cardiomyopathy. So that may include sudden cardiac death, where we're evaluating them to see if they may benefit from an ICD as an appropriate intervention to prevent sudden cardiac death. They may have presented with some of the symptoms of hypertrophic cardiomyopathy and had progressive heart failure from either obstructed hypertrophic cardiomyopathy, far and away the more common presentation of heart failure, as obstruction occurs somewhere between 30% and 60% of those with hypertrophic cardiomyopathy, or perhaps they're in that remaining third where they have advanced heart failure, non-obstructive hypertrophic cardiomyopathy, and although the drug therapies are different, identifying somebody with non-obstructive or obstructive HCM is an important part of how we evaluate those with HCM. Or perhaps they have the most common arrhythmia in HCM, atrial fibrillation, that will increase their likelihood of stroke. So in this group, it's important to identify them as beyond the CHADS-VASc score. Patients with hypertrophic cardiomyopathy are at increased risk for stroke related to atrial fibrillation and often benefit from return to sinus rhythm more aggressively than other groups, and a real benefit with anticoagulations and even proceeding earlier to ablation to prevent some of the complications related to atrial fib and hypertrophic cardiomyopathy. Now, the symptomatic patient journey to diagnosis is somewhat complicated. This is a study published from a collaboration with the ACC and the HCMA that surveyed over 600 individuals along their patient journey and asked them to describe how they ultimately came to a diagnosis of hypertrophic cardiomyopathy. And you can see all the way to the left of your screen, common symptoms overlap with other conditions, pretty typical symptoms for a cardiologist: breathlessness at rest or with exertion, a new heart murmur, an arrhythmia, fatigue, weakness, dizziness with the exercise, or even chest pain or pressure that led those individuals to seek treatment. About a third started with their primary care physician, their primary, with either the family medicine or internal medicine physicians, their primary care providers. About 40%, their initial visit was with a cardiologist, and only about 3% sought an HCM specialist after that initial visit. The primary initial evaluation was a 12-lead ECG, and then based on that, additional testing typically was either a stress test with or without imaging, or an ambulatory monitor like a Holter monitor or an event recorder. And then from there, based on those findings, they could have been referred to a specialist where ongoing assessment with additional imaging like an echocardiogram, a cardiac MRI, or genetic testing may have been employed to help make the diagnosis of hypertrophic cardiomyopathy. Now, two other important points: 37% initially received an incorrect diagnosis or no diagnosis at all, commonly misdiagnosed as a benign heart murmur, hypertension, anxiety or panic attacks, or even asthma as the culprit for their symptoms. And about a third of patients felt that after they had seen their physician, they really poorly understood HCM in total. And what it really brought to life was how long it took for initial symptoms to lead to a diagnosis. And on average, it was about 5 years from initial symptoms to diagnosis and correct diagnosis of hypertrophic cardiomyopathy. So there are some clear challenges in the HCM care pathway, both for diagnosis and, of course, for treatment and evaluations long-term. Some of those are because of limited access to care in underserved communities, or even just remote communities that have difficulty getting to specialty care. It may have been an easily missed diagnosis due to the nonspecific symptoms, some of the slow and insidious process that may occur, or that they had no symptoms at all and just an abnormal family history, electrocardiogram, or a cardiac imaging study, or perhaps due to a limited clinical understanding of HCM outside of large centers, maybe not bringing this to top of mind despite its high prevalence. So these are opportunities and opportunities that we can look to try and identify improvement in the diagnosis and then ultimately the therapy and hopefully outcomes in those with hypertrophic cardiomyopathy. So AI is one of those tools. This is part of the existing literature looking at a 2020 publication that demonstrated the utility of AI to detect hypertrophic cardiomyopathy off a 12-lead ECG. This is the central illustration from that publication in the Journal of the American College of Cardiology, illustrating the sensitivity and specificity at a pretty high mark, about 90% for identifying those with hypertrophic cardiomyopathy just based on their electrocardiogram alone. Of course, we know about 90% of patients with HCM have ECG abnormalities. That's, of course, our ability to identify it. What remains to be seen is in those other 10%, are there other identifying markers that our ability with our own eyes are unable to detect that potentially AI could bring out to help better improve those numbers for diagnostic utility, even with a simple test like an electrocardiogram. So Viz AI is a tool used to try and improve the diagnosis of hypertrophic cardiomyopathy. And it's AI plus referral and follow-up. So not only the ability to review the ECGs and for the AI algorithm to take over to try and help identify who might have HCM, but also to improve the process in total. So it selects preferred notification settings for ECG findings for suspected hypertrophic cardiomyopathy. It allows the user to view patients with ECGs identified as having a suspected diagnosis of hypertrophic cardiomyopathy. You can access the current ECG, compare that to prior ECGs, assuming that they are available, and then collaborate with your own clinical team for further patient workup, perhaps identifying those who may benefit from additional cardiac imaging based on either existing imaging or perhaps they need additional cardiac imaging, a repeat echocardiogram or a cardiac MRI to make the diagnosis of hypertrophic cardiomyopathy or one of its phenocopies. So the Viz HCM AI algorithm was developed using a robust AI development process, including over 830,000 ECG exams from over 300,000 individuals with both obstructive and non-obstructive hypertrophic cardiomyopathy. So a diverse data set from multiple locations globally, including racial and ethnic differences seen in all of the ECG wave morphologies, with 55% being female, 45% being from male populations. And then they validated that using what we consider the gold standard for a diagnosis of HCM, either echocardiography or a cardiac MRI with a similar near 50-50 ratio for men to women. So a very robust population and a very high volume of ECGs to try and cull out and cultivate the algorithm put into place using Viz AI, and then incorporating that into the study Dr. Doherty and Dr. Honeycutt are going to tell us about next.
All right, we have been very fortunate to be part of an HCM clinical workflow study using Viz AI, artificial intelligence algorithm for evaluating ECGs for evaluation of hypertrophic cardiomyopathy. And so the study objectives of this trial have been to implement an algorithm that's been validated for HCM to see how this impacts clinical workflow. And so our hopes in collaborating with this trial have been to see if this type of algorithm and workflow would impact how these patients are managed when they come to recognition based on an abnormal ECG. We've also been very interested in looking at how these types of technologies might expedite detection and improve the patient experience through the diagnosis of hypertrophic cardiomyopathy. Part of the challenge in evaluating and diagnosing hypertrophic cardiomyopathy is really in the diversity of presentation. Many patients come in symptomatic, some asymptomatic, and being able to use an easy, readily available test like EKG would really be a great help in facilitating the diagnosis. So we, as Dr. Doherty and I said, we both practice at HCA TriStar Centennial Medical Center in Nashville. We have been doing this pilot project for the last 4 months. Every ECG that's obtained at Centennial Medical Center is run through this algorithm, and ECGs that alert the algorithm are then evaluated by one of 3 cardiologists who are participating in this study. Our overall team, though, includes research coordinators, which we certainly couldn't do this work without their help. Over the last 4 months, we have had over 9,000 ECGs evaluated by the Viz AI algorithm, and we have flagged 57 patients for follow-up that are then referred to our research coordinator, or direct physician-to-physician contact is made to make sure the patient has appropriate evaluation for suspected HCM.
Thanks, Dave. I'll highlight one of the cases that we've used or identified as part of our participation in this interesting study. So we had a 72-year-old patient who had been treated for atrial fibrillation with a pulmonary vein isolation and AFib ablation some months prior. Her post-procedural EKG had triggered the Viz algorithm, which flagged it for our clinical team, myself, Dr. Honeycutt, and our colleague, Dr. Gentry. We, at a follow-up visit, we were able to acknowledge that because this EKG, this post-procedural EKG, had highlighted the possibility of hypertrophic cardiomyopathy in this previously evaluated patient, we looked again at an old MRI from some years before, which was looked at the time mostly for pulmonary vein stenosis, and we reevaluated it with the auspices, under the auspices of potential HCM diagnosis, and settled on the fact that this was more than likely a diagnosis of hypertrophic cardiomyopathy that had been missed, unfortunately, at that time. The patient was referred to the Hypertrophic Cardiomyopathy clinic, which allowed an opportunity to perform additional testing, including genetic screening and family counseling and optimization of medications to avoid the potential for LVOT obstruction. I think this case really highlights what we've kind of been talking about and what we hear so much about HCM in delays in diagnosis, people who are part of being evaluated for symptoms for other reasons, part of the system, but the potential for hypertrophic cardiomyopathy as a contributing factor to their presentation is sometimes missed and delayed for a variety of different reasons. And just using a simple tool like the EKG to highlight again potential cases that may be flying under the radar is a potential helpful adjunct to the clinical practice that we're already participating in.
All right, so excellent discussion. I want to expand on a couple of those things. Dr. Daugherty, can I start with you for the question? Where, when I was going through my portion of the slides in the 2022 patient survey, it took 5 years or more for many patients to receive an accurate diagnosis of hypertrophic cardiomyopathy. So you touched on a little bit of this in your last comments there. How does the clinical workflow factor into the delay of time to diagnosis for HCM?
I think it starts really with the thought process that I think when people are being evaluated for new symptoms in a cardiac practice or even with their primary care provider, I'd say it's pretty rare that someone is settling in on hypertrophic cardiomyopathy as one of their initial diagnoses that are high on the list. We talk a lot about heart failure, coronary artery disease, non-cardiac causes for symptoms. And as people go through these evaluations and they get evaluated and you find things that you think may explain their diagnosis, or people are just, frankly, think that their symptoms may not be related to any underlying cardiac etiology, that's inherently delaying it. So if you're guiding people towards an ultimate diagnosis earlier in their evaluation and making sure that they have the appropriate diagnostics performed that make it, that can point you to or away from hypertrophic cardiomyopathy as a potential in a symptomatic patient, I think that's a powerful tool, cutting down months and sometimes years, as in this case, that would have, you could have been dealing with the patient's symptoms at an earlier time.
So no question, given the prevalence of this condition, it really kind of ought to be top of mind when we start evaluating a patient with similar symptoms. And of course, many of the symptoms are slow and steady. There's not an abrupt change, right? They come on often over years. So even the patient themselves seems to kind of downplay that. So as you think about current users, I need Dr. Honeycutt and Dr. Daugherty both probably to weigh in on this about what challenges with hypertrophic cardiomyopathy have you all identified that you think artificial intelligence, AI, is going to be able to address? Tell me about kind of some real pearls of wisdom on that one.
Well, I think that, when I think about this, and I would just add to Dr. Daugherty's previous comments that, I think a lot of times when we meet patients in the cardiac practice, we meet them after an acute event. And so there's been some episode that has prompted cardiology care. Maybe it's a symptom, but often it's a discrete event, a heart failure admission, an acute coronary syndrome, a diagnosed arrhythmia. And so I think what makes HCM a little more challenging is really just the heterogeneity of symptoms with which patients come in. And sometimes the symptoms can be quite insidious, really not differentiable from people with, say, benign palpitations or just mild dyspnea that you think might be due to even a non-cardiac cause. So I think that for me is one of the challenges in my personal clinical practice in keeping HCM at the forefront. to answer your question, though, I really think that the most what the promise, I think, of AI needs to be to take a test that by human interpretation cannot differentiate HCM from other causes of LVH or other pathology, and use that very easily obtained cheap test and use it in a fresh new way that really adds value to the test above and beyond the human interpretation. And that's what I think we don't quite know yet, how much AI is going to help us in transforming already available technology and just making it better, because we're integrating all these algorithms that are able to learn from, ingesting all of this data and looking at it in ways that the human eye and human brain can't really do. So that, for me, is why I'm very interested in AI and as a research tool, both in this ECG HCM space and also in other places in cardiology, especially in even the imaging setting with echo, MR, and CT.
I think those are great points, Dave. I think from my perspective, I would agree with you on most of it, that what you're trying to do is kind of bridge an experience gap. So the EKG is so ubiquitous in terms of, who's doing them, but in terms of interpretation, there's a huge amount of variability. So using an AI algorithm to improve the quality of interpretation, so that a primary care provider, so that an advanced practitioner working in a rural setting can use a tool that will bring their EKG interpretation to the level of, Dr. Martinez or an experienced cardiologist in HCM to guide them accurately and appropriately to a diagnosis and facilitate a workup at an earlier stage is a potential intervention that would make significant difference in the lives of these patients and many more. With other cardiac conditions, so I think there's a huge potential there within cardiology.
I agree. Excellent points. I mean, I think it's going to, the promise, as you say, is that it's going to escalate and allow some scalability to what we already use routinely and hopefully improve on that. So let's talk about the trial experience. So HCA, thankfully, was the first institution to trial AI for this disease state, at least. What made you both agree to pilot this? If you're someone out there considering, being part of this research study, what kind of pushed you to say, I think I want to be involved?
Well, for me, my role, one of my roles within HCA is to sort of vet and listen to research ideas and sort of see what might be a good fit for our network of hospitals. As you may know, HCA is the largest hospital corporation in the country, 190 hospitals and freestanding centers. And so we see a lot of patients. And frankly, it was, watching, my partner, Dr. Doherty, set up our hypertrophic cardiomyopathy clinic and seeing what a great clinical need that fulfilled for our practice and for our patients, and just wanting to bring the opportunity for research and driving these patients to the care that they really need. We've seen in our practice just the transformative power of a dedicated HCM clinic. And I think what we need to complement that, now that we have specific, drug therapy, surgical therapies, and freestanding clinics that do HCM, is some way to drive patients to those clinics at an earlier stage. And so I think that for me was what really made me interested in this type of research application.
So if you think about the total volume, right, this is an opportunity to really kind of sift through a large volume of EKGs. Like most places, you're doing hundreds, if not thousands, on a regular basis. So this is an opportunity to try and dive into that. So how does the Viz HCM pilot work at your study site? Can you give us some insight into what that looks like?
Yeah, so what we do is we have 3 cardiologists, all of whom have an interest in diagnosing and managing patients with HCM. We have a mobile app, which all of us have available. All of our inpatient EKGs are fed into the system. They go through the algorithm, and we get a series of EKGs for our independent review. So these quote unquote HCM suspected cases. We then do a clinical review. We review their prior imaging, we review their admissions. We look for alternative diagnoses that might explain the presence or absence of hypertrophy by EKG or by other advanced imaging. We then decide whether the patient likely or unlikely has HCM based on the diagnostic clinical criteria and the 2020 guidelines regarding HCM. And we just make sure that that patient is getting appropriately followed. Like Dr. Honeycutt mentioned, having a dedicated HCM clinic is a powerful tool because previously I think there was a lot of fear and intimidation in terms of managing these patients, both in terms of inertia and inability to do anything for people short of septal reduction therapy, and risk of sudden cardiac death, which people felt like it was hard to quantify. But we embrace those challenges in the clinic. So bringing them in and evaluating them and working alongside their cardiologists, the primary care providers, and most importantly, the patient to improve the quality of their care at an earlier stage in their journey is the potential here. And it has potential to make a huge impact in an underdiagnosed population.
So clearly improve the process, right? It sounds like you've improved the process and really restarted. Dr. Honeycutt?
Yeah, and I would just add, I mean, those are great comments that, Brian just said. I think the app is designed to not only, flag the patient for a suspected HCM case, but also it's designed to be a communication tool for members of the team. And so that's kind of what the app, the thought process around the app and the workflow is, that can you kind of aggregate the people that are involved in the care of these patients, whether it's doctors, mid-level providers, nurses, to use this as a communication tool. So the app not only has an ECG viewer that allows you to review the ECG and look at priors as well, but it also allows you to send messages within the app that are, obviously privacy protected to other members of the team to say, hey, this patient we need to know this primary care doctor's name so we can reach out to them directly. And in the research environment right now, members of the team are basically the doctors and the research coordinators in our research practice. But I think, if this were done outside of the research setting, that team may look very different, and may vary from institution to institution, including the level providers, nurses, administrative staff, schedulers, stuff like that.
Well, it sounds like the experience has been good, even though it's a high volume, right? You're going through almost 10,000 ECGs. Sounds like you've been happy with the experience. What surprised you? What came of this that you didn't expect?
I'll start with that. I think that the app is very well done in terms of how the user interacts with it. I think that I was a little bit of ulcer about knowing that 10,000 ECGs in 4 months were going to be fed through the app, and it is some work. It does require, I think, some dedicated time that the three of us have certainly spent some time doing, but it hasn't been quite the deluge that I thought it would be. So that for me was a surprise. I think the usability of the app is also very good. That has been a pleasant surprise as well. I don't know if Brian has further comments on that specific topic.
I think the large volume of EKG is certainly intimidating, but the fear of all these undiagnosed and missed cases and alternative diagnoses that people walk around with, I think that's what's kind of driving us is how do we do better? And so trying to utilize this as a tool, that's really the driving force behind it. So every time we have something that we think is HCM, we're doubling down, making sure that this person has appropriate follow-up, that we're happy that the circle has been closed, that someone has said the words hypertrophic cardiomyopathy to these patients. And we're doing that all starting with just an EKG trigger, which is to this point hasn't been that way. I know the case we highlighted was an MRI that we reinterpreted, but you think about how many EKGs we're doing and the potential to pick up more patients. If we can really solidify this algorithm and really be as accurate as possible in terms of diagnosing these patients with a simple EKG, there's the potential to be really powerful.
So expand on that a little bit. What about other cardiovascular disease states? So certainly there's overlap. In our program, we are often making other diagnoses. So it's not just HCM, right? I mean, you're really talking about a change in how we evaluate thick hearts in total.
Yeah, and I would add to that, I think we have seen, this algorithm is extremely good, I feel, at detecting LVH. I think that we rarely have a trigger where there's no pathology. I'm not saying it hasn't happened, but that's an uncommon scenario. We tend to trigger on either HCM, aortic stenosis, LVH from hypertension. And I think part of that is going to depend a little bit on the population that's being evaluated. So for instance, with us having a predominant inpatient volume, we are getting some non-compliant hypertensive patients. We have a very robust structural heart program. So we get triggered for every 80-year-old who's undergoing a TAVR eval. And Brian may want to comment on this too, but I guess I feel okay about triggering on pathology. Most of the time we're triggering on some type of structural abnormality that we're able to confirm with either prior or subsequent imaging. Not as sure in our patient population, the specificity of the algorithm for HCM versus other causes of LVH. I think that will remain to be seen, and hopefully will improve with time and more learning from the algorithm.
I think LVH as a marker of cardiac stress, I think is important, whether it's a primary genetic issue or some kind of secondary underlying etiology, but recognizing it with an increased frequency and specificity. I think there is a role, like Dave said, it's important that we don't have alarm fatigue from all these LVHs from alternative diagnoses. And that's going to be one of the challenges in terms of integration into clinical practice, I believe. That the accuracy, we have to be confident that the accuracy is such that when we get a trigger that we know that there's something there, be it HCM or otherwise, so that we truly believe that it's actionable. But LVH from other causes is, some of the EKGs have been surprised by how normal the EKGs look when we look at them in the viewer, things that wouldn't have triggered our minds necessarily to think about LVH as a potential. The algorithm has picked them up, and like Dave said, it's rare that we don't see some form of underlying pathology there.
So you mentioned some important ones: hypertensive heart disease, aortic stenosis, clearly infiltrative cardiomyopathies, amyloid and Fabry will end up in that category. So even as you say, if you trigger, you're going to identify important other diseases as well. So this is sort of just good for patient care. Do you see beyond ECGs, there's a role for other diagnostic imaging modalities going forward, or is it too early to tell?
I think there is, I think with this talk, and Dave alluded to it earlier about, within echo and MRI and CT, I think that, everybody is looking at those spaces potentially again, to avoid inter-observer variability and accept the fact that they're, as individuals, that we miss things and make mistakes. And if we can bring up the quality of our diagnostic imaging to a more uniform standard using whatever tools we have, and AI is certainly one of the more powerful, has the most powerful potential, I think, in terms of the current environment. I think that's a potential to further it even more in terms of underdiagnosis of conditions that have very significant and meaningful clinical outcomes.
Yeah, I think too, I completely agree with what Brian said. I think that the other opportunity for AI to really help is not only in, supercharging, so to speak, a very fundamental tool and making it more accurate and more diagnostically useful, but also speed. And I think we're seeing in the advanced imaging space and imaging in general within cardiology, that's where AI is also starting to flourish with taking something like automated border contour detection with CT, MR, echo, and really making it so much faster. So we've been, engaging with, folks that do that type of work on the research side as well within HCA, just trying to explore ways to optimize workflow across the cardiovascular service line in multiple different domains. And imaging is probably one of the main ones we're seeing. I think of plaque characterization with CT, border detection, strain imaging with echo, HFpEF detection with echo. All of those things really lend themselves to getting some help from AI.
Yeah, so much of the discussion, I love every point so far, but most of the discussion has been about diagnosis. So let me make you shift a little bit towards the treatment algorithm. So do you see a role for AI? You kind of touched on it at the last statement. That's what made me think of this, about a treatment paradigm shift. If we use AI for what you're describing, how's this going to impact treatment?
In terms of response to treatments, you mean for advanced imaging?
Yeah, I think the diagnosis is important, but you kind of touched on how it may trigger treatment earlier, right? So preventing the delay in diagnosis. And obviously we're seeing, because this algorithm can identify both obstructive and non-obstructive, is this going to have an impact on the utility of some of the new medications like cardiac myosin inhibitors, et cetera?
Yeah, I think absolutely. I think on both counts, right? So certainly the paradigm has changed hugely, as you well know. Dr. Martinez, with the cardiac myosin inhibitors, I feel it's been a real game changer in terms of obstructive patients, and we're hoping to open that up to non-obstructive patients based on the results of ongoing clinical studies. And I feel like the non-obstructive patients get an even later diagnosis. They don't have the LVOT obstruction. They don't have the gradients of 80 millimeters of mercury, at rest that can be easily missed. So, recognizing those patients earlier, especially as you're opening up treatment options for them. And like I alluded to earlier, people felt lost managing HCM patients not that long ago. There wasn't that much to do for people who weren't surgical candidates. And so I think it's a really exciting space, both HCM and AI, and the marriage of both has a huge treatment potential for a very vulnerable group of patients who've been overlooked for a long time.
Agreed. Even beyond the myosin inhibitors, right? Identifying somebody who might benefit from an ICD, or someone who could be put into one of the new calculators for identification of risk for atrial fib. We can intervene early in somebody who, and just as your case alluded to, really important. I was worrying most about the undiagnosed, the untreated, right? The unprepared individuals. Any last points that I haven't hit on, or should we move to audience Q&A?
I think just, again, to your point, the undiagnosed, I've made the point before that when we're taking these 3-generation family histories for patients living with HCM, they're often, unfortunately, filled with some really sad stories that you wish you had met the uncle, the cousin, the brother, the sister, the parents at an earlier stage, and said, that kind of side of things, the sudden cardiac death screening side of the HCM treatment algorithm, like you mentioned, is extremely important. And early diagnosis is so powerful. If you have more time to make the diagnosis, discuss with people, do the advanced imaging, talk to them about defibrillators, you're aiding the patient in terms of their understanding at a much earlier stage in their disease process.
All right, terrific. Let's take some audience Q&A at this point, and we'll keep the discussion going.